The reason we're calling it auto augmentation is not because we love our Lotus and our Lamborghinis and auto meaning from yourself, right?
An auto-augmentation means using the surrounding breast tissue that's already available in order to augment, as opposed to an implant augmentation or a fat graft I'm sorry, or a fat graft augmentation.
Okay. And so let's talk about you said there's a couple different techniques and you use all of them and you might even use all of them on one patient depending on what they need. So go into a little bit about first of all, what's that main goal that we're trying to achieve after the surgery and then how you get there and what your different techniques are.
There's lots of techniques described in literature. If you look, there's a lot of variations of the same sort of principles. But bottom line is there's a lot of tissue on the bottom of the breast that typically during a lift just gets sacrificed. And it's usually thin. It doesn't amount to a whole lot of volume, but hey, it's better than nothing. So instead of cutting it out, if we can just deepithelialize it, which means we remove the skin from the surface of it, but then use the tissue immediately beneath it and preserve the blood supply, we can actually take that bottom of the breast, lay it down on the chest wall. I actually use that opportunity to repair the muscle too. A lot of times patients ask, after we remove my implants, are you going to repair my muscle if the implant was under the muscle? This is a good opportunity to do that, where you redrape the pectoral muscle lower and sew it down to that breast, the lower breast tissue. That accomplishes two things. It gives us an extra layer of tissue on top of your chest wall in order to then reconstruct the breast on top of that. So we already are starting off with a little bit more projection, a little bit more volume, and it restores the natural pectoralis major anatomy to what it was prior to the augmentation. So it's kind of two benefits in one maneuver. There's a second opportunity where immediately beneath the nipple, a lot of times, basically, there's a little bit of extra tissue immediately below that nipple. And what we do is we basically do the same thing. Instead of removing it or cutting it out, we remove the skin from the surface of it, but then we use the tissue beneath the nipple in order to kind of flip it underneath the nipple and the areola, and that will give us a little bit more projection of the nipple itself. Sometimes there's actually enough that we can flip it underneath and hike it up higher so that we actually give a little bit more upper pole fullness as well. So that's a great technique to just achieve central projection, central fullness of the breast. In addition, that particular one is my favorite because we can actually manipulate it towards a deficient area. If a patient has very little volume centrally, we can actually take that flap and kind of move it towards the center a little bit more. If there's volume deficit laterally or on the outside, we can do the same thing. We can just kind of move it towards the outside, or we can move it to the upper pole, or just immediately beneath the nipple in order to give a better projection. But again, it gives us a lot of flexibility and really tailor that result to the individual patient based on where their tissue is the thinnest or based on where they need or want most volume. So those are the two sort of primary ones that I rely on. And the third sort of auto-augmentation technique is really just the outer and the inner parts of the breast that are left over. We just kind of bring them together and therefore up to kind of hold that almost like a bra, hold the remaining two parts together and in place, just the way I described them earlier. So a couple of different areas of opportunity where we can really save that tissue and optimize that result. Again, they take a little bit more time because we do have to take the extra step of removing the skin from the area around the areola, removing the skin from the bottom of the breast. Then we are very careful to preserve blood supply. So this is usually a very meticulous surgery, very careful, very precise, so that we don't damage any blood vessels in the process. So all this tissue actually survives. We have to then, rearrange the breast tissue. Usually there's a step during every surgery where I basically give myself all three of those opportunities. Pretty much for every case, I use all three of these. It's just a matter of some patients have more on one area, but less in another, and vice versa. But I sort of give myself all of these opportunities for every case. So I take the extra steps to remove skin from every case. And then I see what I have in front of me in order to then, put the pieces back together like a puzzle, like a three-dimensional puzzle, and arrive at the best, shape and volume that I can, and then get that final result.